of the societies. So it will be a number of around 20 million people being 60 years and older. And if I take a 20% prevalence rate, we have millions of people in Germany. We are 80 million people. We have 5 million. And the US already in former years said that 58 million are estimated to have actinic keratosis. From more than 300 million people, a fifth or a sixth of the population is going to have actinic keratosis, a fifth or a sixth. And someone else said it's the second most common diagnosis in the US. And even in my private practice, every second patient comes with this diagnosis, and they want to be treated. The subject is not urgent. Some people say, oh, you can wait. And there is a regression of some actinic keratosis, but they can reappear. Is it a healing when you're old enough to have all these mutations? I will show you. It's urgent if we trust to be a risk for the development of spinalioma. And what we can say from literature, 10 to 20% develop over years from AK to SCC. If the number of the AKs is increasing, 10 actinic keratosis make a higher risk. Like the immunosuppression, age of patients, men are more prone than women. Field cancerization is a word that we have to keep in mind. 70 to 90% show a coexistence of actinic keratosis, like here, with spinalioma. And 60% of spinalioma are on top of an actinic keratosis. There is a coincidence, and there was just a publication showing that you have actinic keratosis grade 1, so not grade 2 and 3, a continuous development. You just get a skip, hit and run. There will be a spinalioma from actinic keratosis grade 1. We need further publications for that. This is a kidney transplanted patient. He developed in a very short time such a spinalioma. More aggressive courses with immunosuppression, and we have immunosuppression in rheumatology and psoriasis, so we have a great clientele of patients being like this. Field cancerization, defined as an area with solar elastosis, AKs, grade 1 to 3. It's not obligatory to have a spinalioma in it. The European guidelines say you have to have 6 actinic keratosis. The number deviates from 5 to 6. Some actinic keratosis, field cancerization. Our handicap still is that we don't know which actinic keratosis is becoming when, at what time point. I can't tell my patient. So I'm somehow urged to treat. And this is in the background. I trust it that it is a continuous, at least a continuous development, that there are gene mutations, activations, and suppressions, oncogenes working in the same direction as spinalioma, and they are named over here. We know that the correction phase, the metaphase is disrupted, that we don't have the apoptosis, and we have melanocortin receptor, TP53, everyone knows about that, the hedgehog pathway, the xeroderma pigmentosum, which cannot correct DNA mutations. This works together to become a skin cancer, non-melanoma skin cancer. The pattern shows it. And we clinicians have to say, what can I see that I have to treat? I'm still with these little rules that I can say lip, nose, ears are more prone to become spinalioma. If it is a growing diameter, I have to take care of infiltration and inflammation. Then we go to the therapy. Worldwide, I asked all the German companies, and we have quite a bit, what do you present in which state? Where do you sell your products? Why and which status do you achieve? So we go. A lot of different therapies are available in different parts of the world. The decision criteria should be all the same. Is the therapy available? And then you come to the pharmaceutical companies. Severity of clinical findings and side effects, that's the doctor with the patient. We decide comorbidities, co-drugs. Had he had a tumor before? What's the cost, and the reimbursement is again the politics and the insurance companies. And I can tell you that at least in the United Kingdom, you get cryotherapy reimbursed, but not the local therapies. So this is a major point for the patient. Can he afford? Can he pay? We come to country specifications. This is a table as it is seen in the German guidelines. You have the destructive therapies, one line, topical therapies. This is also a field therapy. Laser therapy is used very often, is well paid in Germany. Cryotherapy is used very commonly. Shave excision and electrocaustic in the operation theater if you do an operation. Destructive procedures like cryotherapy seem to be preferred also in Italy and France. I will show you. And it can be read and that it is recommended in Australia, Canada, and United Kingdom. Australia, Canada, and United Kingdom. And the European guidelines also say cryotherapy as a lesion-directed first-line therapy. This is important, but these are for field therapy. I will go to this. Since 2000, the strengthened definition of a case as a squamous cell carcinoma in situ and the increasing pronouncement of field cancerization show that we got more by the EMA-approved drugs. This was well known for decades. Then we got in 2001 diclofenac, 3%. In 2006 we got 5% imiquimod Aldara. FDA is always faster than EMA, 1 to 2 years. That was 2004 from the FDA. 0.5% 5FU was much more known in the US before we became this product in 2011. The last two were coming up on the market 2013, 3.75% imiquimod, Tuclara named in Germany, and ingenol mebutator with these two substances. The well-known action mechanisms, most of it is immunotect with the neutrophils or T lymphocytes, TNF-alpha or interferon. Diclofenac goes via arachidonic acid. Decrease and increased apoptosis is described for all of them, and we have the chemotherapy, the antimetabolite drug 5FU. All work for the tumor development to stop it. Country specification will say diclofenac is established in Europe and Australia twice daily for 90 days. It's generally used, comfortable for the patient. Australian guidelines, you see they have a major problem, already discuss the combination with cryotherapy. My patients love the drug because there's not much inflammation and the elderly man says, I have it beside my bed, I use it each time when it's necessary. I don't know whether this is the right way. It's generally and very common, has high rates of selling in Germany. Country specification for imiquimod. It's approved by EMA and FDA. You can buy it in Arabian countries, Israel, Iran. It's a field treatment. If we are correct, this field is a limited field, 5 times 5 centimeters. You can do more. But in the description, it said this way. The cycles in Germany used 4 weeks. You repeat it normally twice, 3 times a week. In Australia, it was normally 12 to 16 weeks, and we started with that in the 90s. But Australia, doctors practice the same 4-week cycles, very common, very comfortable for the patient to control the side effects. 3.75% approved by the EMA and FDA is not yet available in Arabian countries. It's a field treatment. It's allowed up to 200 square centimeters. The whole bald head and the whole face is allowed. Definition, which was new with the LMAX, the maximum treatment even of subclinical lesions. That was interesting, and I trust it. They come up, and the patient said, it's side effect, and I say, no, they come up, I can see what's in your skin. Twice, 2 weeks, make a 2-week break, 2 weeks again, once daily. This product is available in the USA. We had studies in Germany too, but they didn't convince. We have no approval from the EMA. Samples, I show this especially as this is the normal region which can be treated with 5%. This is the bald scalp with the subclinical lesion shown up under the treatment. 5FU, well known to me since my very beginning in the 1990s in dermatology, and then the product all used in the US. We didn't have them all until we got this combination with the salicylic acid. In Northern Europe, Canada, Mexico, once daily, 6 to 12 weeks. We just try to come to get a good result with 4 weeks. They do have side effects if they use it on a bigger area. 5% used in many, many countries, and I found this example in internet. And when I tell, this is quite a huge region that you can treat, and some people have problems with the side effects, but I think it's a very good drug. Ingenol mebutate, the 2 concentrations for the face, 3 days, for the rest of the body, 2 days, approved by EMA and FDA, Canada, Australia, Brazil, not yet approved in Arabian countries. It's also, until now, a limited field. They work on it to make it a bigger field, still a limited field, the days. And what's now coming up with the publications, but we don't have the comparative studies. With the publications, they say all people like 3 days. It's comfortable, but the side effects can look like this. This is after the first day, second day, very typical pustulation, and the third day, and after 12 days, you might still see the reddening of the skin. Also a very effective drug, but we have to know about the side effect and communicate with the patients. Now I come to the countries. We started, Eckhart Stockflate published very nicely in 2008, the algorithm. We do have 2 categories, the lesion-directed and the field-directed category. We find that in all other countries. If you have only points, you go for destructive. You can shift towards the local therapies. And if you have more, you see in line diclofenac, imiquimod, PDT, 5-FU, and sun protectant, of course. This was Germany, and we should work on it right now. Drano published in 2014 in an AK team. If you have isolated AKs, you do cryotherapy, destructive, and even surgery, second line. You see, there is a focus on the destructive procedures for isolated lesions. Multiple lesions, we are in the same field with all the product I named before. This is France. This is Spanish. The European guidelines list the products Spanish people tell. Sun protection, of course, protection. Few lesions, you treat the lesion again with the destructive procedures. Medical treatments, all that I named before, inclusive ingenol mebutate. And I can't really understand. Now you see the field treatment. You don't have ingenol mebutate in it again. It's the same size like 5% imiquimod. 5% imiquimod is 5 times 5 or 25 square centimeters. Ingenol mebutate is the same. You find Aldara, 5%, but you don't find ingenol. Can't really understand. It's a focus. It's how they prefer things to do. Not really understandable from the description of the drug. Now, broaden the view, Canadian Non-Melanoma Skin Cancer Guidelines Committee. They say clinical evaluation, single AKs, clustered more. They don't talk about field cancerization, clustered AKs. You do destructive procedures, nothing against it. You do topical treatments, 5-FU, imiquimod, ingenol mebutate. They don't have diclofenac in it, okay? Smaller deviations, but deviations. And they say you can do other things in the hands of someone who is familiar with that. And I was very astonished. I just prepared my talk for this, and I found this publication. You see how many countries work together already. They want to do more or less an international standard of view. Stockflate is publishing it just now. And they say increase the awareness, what I try to do here. Develop topical therapies, address concerns. Quality of life can be decreased. Simple regimens should be successful and communicated. Let me summarize it in this yellow pattern. Inform the patients and the doctor and the physicians. In some countries, Australia and UK, there are also normal doctors, general practitioners who work on it. Short treatment, it should be efficient, otherwise the patient doesn't adhere and doesn't finish the treatment. Warn about spinalioma, give it all away. And this is one thing I want to add. You can work also convince the state and the law. And I think Germany was very successful with this example that we have an UV occupational disease. Is it in any of your countries? We have a law that people who work like this farmer outside, and you see the damage, UV damage, and this is his normal skin. And several years outdoor, it should be at least something like 10 years when you're 60 years old. You have a UV damaged skin, you work outside, have a field cancerization, now it's 5 AKs. You can have a spinalioma or a Morbus bone. In the law, it's still not accepted that we have basalioma from UV damage. We have 2.5 million workers. They get lifelong payment for all therapy costs. And that means even laser therapy, and it is paid by the social insurance. Diagnosis can even be made when they are retired, and employers must offer sun protection. I think this is something that is really bringing us forward for these people suffering from UV and actinic keratosis. Further challenges is a sequential therapy. Australia works on cryotherapy and diclofenac. Other countries offer proposals, still studies are needed. We do have problems with fragile skin, atrophic skin, poor healing, the bald scalp, the legs when they have atrophic skin. You do something inflammatory or surgery, it is not healing well. We should work on that. Improvement of long-lasting. I don't want to see a patient too often. Let him come once a year, once every 2 years, and he will be happy to spend his time with 60 years everywhere else. Can we get a therapy of the whole integument? Can we search for systemic therapy? And you see, I do have quite a bit of patients having the whole body, the whole skin, like there's actinic damages, and we work on the field therapy, for example, with these two products, even in comparison, what is the better result? What does he like better, the patient? My summary: actinic keratosis, a West European breed, many international similarities in the treatment, but we have some deviations, and that cannot all be explained by reimbursement. A consensus of therapy algorithm would be nice, explanations for deviations, recommendations for sequential or combined therapies should be aimed, and my point is the priority of the treatment options should be rated by the compatibility for the patient, the outcome, with a possible synchronizing activity over the countries. Thank you very much for your attention.
Thank you, Dr. Nashan. I definitely think there is like a lot of cross-country travel, and we in America, we see Europeans. You in Europe will see Americans, though less, I think.
Yes.
Europe is becoming expensive for us. Questions open to the floor?
So is it known what is the mechanism by which the emicomode actually function?
By which the?
Emicomode.
Mechanism of emicomode function.
Emicomode, Aldara? What is mechanism of action?
Okay.